Good morning and welcome to Sickle Cell Disease, a Community Conversation. My name is Reginald French, President and CEO for the Sickle Cell Foundation of Tennessee. I would like to welcome you to this very important program on today, which is hosted by the Sickle Cell Foundation of Tennessee, Mount Zion Baptist Church, Nashville. I would also like to thank our sponsors on today, Hill Collaborative, along with Vertex and CRISPR Therapeutics. Sickle cell disease is a rare disease that affects approximately 100,000 Americans, 10 million people worldwide, and approximately 300 million individuals carry the sickle cell trait. It is predominantly a disease that affects people of color, African Americans. The purpose of this program on today is to raise awareness in an effort to improve health outcomes, as well as for people who are living with sickle cell disease from childhood to introduction. Today, our program will consist of three panels. We have three panels, which are the physician panel, patient, caregiver, and provider panel, public policy panel. At this time, I would like to acknowledge all the panelists prior to starting the first panel. The panelists are Kiara Y. Moore. Ms. Moore is also a co-host. She's the Health and Wellness Ministry Coordinator for Mount Zion Baptist Church, Nashville. Dr. Adatola Kasim, who is the Associate Professor of Medicine and the Director for the Adult Sickle Cell Disease Program, Vanderbilt University Medical Center. Dr. Richard L. Martin, who is the Medical Director at Meharry Medical College. Dr. Lamitra Scott, PharmD, who is the founder for Breaking the Sickle Cell Cycle. Alexis Gordon, State Director for the Sickle Cell Foundation of Tennessee. Dr. Maria del Pilar Aguinagua, who is a professor at Meharry Medical College and also the director for Meharry Sickle Cell Center. Dr. Harold M. Love, as well as State Representative Harold M. Love, Jr. for District 58, Nashville. And our final panelist is Howard A. Mosby, who is a Georgia Safety Net Hospital Administrator. He served in the House of Representatives for the state of Georgia for 16 years, and he's the treasurer for the Hill Collaborative. I'd like to thank you all for participating in the panel today. At this time, I'd like to start with the first panel. The first panel will consist of the physician panel. Our first speaker on this panel is Dr. Adatola Kasim. Good morning, Dr. Kasim.
Good morning, Reginald. Thanks a lot for that introduction.
Thank you, and thank you for joining us on today. Dr. Kasim, you're going to start off this morning kind of giving us an overview. What is sickle cell disease? How does one get sickle cell disease? Along with what is sickle cell trait? So at this time, I would like for you to start discussing to the audience, what is sickle cell disease?
Thank you very much. So I'll go to my slides. Thanks for that kind introduction, Reginald. I think we've come a long way since trying to advance my slide here. Yeah. So like you all know, I didn't know I was knocked off. All right, all right. Do we have that now? Yeah, so thank you. So like you all know, we've come a long way from the description by James Eric more than 100 years ago, when it was noticed that sickle cell was a peculiar, red-shaped blood cell in a medical student from Granada. So over the years, it was described that clearly sickle cell disease is a blood disorder in which there clearly is a genetic change within the proteins that constitute hemoglobin, which we call the globin chains. To just give you a little perspective about this, when you see the red blood cell proteins, we say they're made of what you call your alpha and beta chains. And within those proteins, you have what is called iron. So all these are bound together, and it's important, that they blend together well because they clearly carry oxygen. So those two proteins, which we call 2 alpha and 2 beta, each one of those is inherited from each parent. And so when they're all normal, we say we have normal hemoglobin A. But if one of the beta proteins is inherited from one of the parents, then you say you have the S mutation, which typifies sickle cell disease. If it's only from one parent, we say you have the trait. That means you have normal alpha proteins, but in terms of the beta proteins, you have one normal and one which is designated as the S from one parent. We say you have the trait. If you have both abnormals, then we'd say you have sickle cell disease. That means you have 2 normal alpha and 2 abnormal beta. Now, sickle cell is not the only abnormal protein. Occasionally, there are other variant blood disorders, and so you could also inherit what you call C abnormal, protein from another parent, and that with an abnormal S, we say you still have sickle cell disease, but it's called SC. So this causes a lot of confusion in the community, what type of sickle cell disease you have. So you could have SS or SC. But we've moved a long way from when people like me were in medical school, and it's quite clear that hemoglobin S, just inheriting that abnormal protein S from one parent or both parents, that we've actually evolved beyond that. And what you find out is the protein complex, which I described to you, with the mutational change, what you end up getting is during specific conditions in the blood, they gel together, and they cause this abnormal shaped red blood cells, which you can see in the peripheral blood down to your right, which clogs the vessel. And of course, the problem there is those red cells are damaged and they become a problem. This movement in the capillaries illustrates what you get when blood that are sickled are trying to get around. You can see that it kind of gets sticky and stuck in the blood vessel. And this is what causes some of the problems you see in sickle cell disease. But it's important to illustrate again that there are different types of sickle cell disease. We've talked about the hemoglobin S. This is when you inherit those abnormal proteins from both parents, and we call that the SS. It's most common type of sickle cell disease. You inherit one sickle gene from each parent, and is one of the severe forms of sickle cell disease. I spoke about the SC, where you get one of the sickle gene from one parent, but the C gene from another parent. There's another variant called S thalassemia, which really is partly inheriting the sickle gene from both parents, and in addition, having a defective production of red blood cells, which invariably allows the S to be the predominant protein. And again, that is what we refer to as sickle thalassemia. There are other ones described, especially in other parts of the world. We've seen what you call SD. We've seen a few SE, which has to do with a lot of interracial marriage between maybe African Americans or people of African ancestry and people from Southeast Cambodia and those areas. And we have SC and even SO Arab. So sickle cell disease is not monolithic. The important thing there is you have these variant abnormal proteins that cause what you call the sickle cell syndrome. Also important is you have to be diagnosed properly. And the way you're diagnosed is either through what we call hemoglobin electrophoresis or what we call a high performance liquid chromatography. The sickle decks we do in the emergency room or in the clinic, where they just test your blood and say, oh yeah, you've got some sickle cells, does not diagnose you. You have to have the proper diagnosis so they can characterize whether you are SS, SC, SD, SE, because they all have different variances. Um, Also, to add to the complexity this morning, because we're now in 2020, sickle cell disease we're beginning to understand is more complex. Because if you, as most of patients know, as well as providers, not all patients are the same. They all have different manifestations. And what we're beginning to understand is if you look at all these common complications of sickle cell disease, like stroke, pulmonary hypertension, what we call acute chest syndrome, kidney damage, avascular necrosis, we're now beginning to understand that there actually are other individually inherited genetic um, variants that come with each population that allows people to manifest these complications differently. So some patients are more prone to kidney damage, others are more prone to uh, joint damage, some are more prone to stroke, while some are not. So it's critical within the community that once through newborn screening, a patient is identified to possibly have sickle cell disease, we need that follow-up to properly characterize your disease. We know this is a global disease with an estimated prevalence of 2%. In the US, like regional said, we're running about 100,000 within, but the epicenter of this disease still goes back to Africa with more than 2 million patients. If you look at population prevalence of sickle cell disease, more than 40% carry the S hemoglobin, even in some African regions. But in the US, it's a predominantly African American, most affected are African Americans, with those with the trait, which we refer to as AS, being 1 in 12. That's 8.3% live births, while those with the SS is about 0.27% live births. S is 1 in 835 live births, and S beta thalassemia 1 in 1,667 live births. But there's a lot of global inequality. As you can see, childhood survival for sickle cell disease has improved tremendously in the US and UK or high income countries, but it's still lagging in the epicenter in Africa, where the chances of survival goes down to 10%. We have clearly evolved over the years. I would say for more than 50 years, this was purely a neglected disease in the United States. But over the years, through the incorporation of the National Sickle Cell Anemia Control Act, and incorporation of penicillin prophylaxis, the multi-center trial for hydroxyurea, stroke prevention trials, and incorporation of what you call newborn screening, things are beginning to look, better. And so if you look at sickle cell disease, it still causes a lot of extensive morbidity and early mortality. That is, we talk about damage to the organs, like I said. And if you look at the survivor, based on some of those things we now understand, we've been able to move the increased early death, like we're still seeing in Africa, to later part of life. So if you look at this graph, we've kind of flattened the curve of survival, of mortality in children, and kind of shifted the curve to the right. So what it's telling you is that we're still seeing a lot of death in adults. So there's been an improved survival in sickle cell disease, especially in children, which has really improved over the last couple of decades. And part of this benefit comes from the incorporation of prophylactic penicillin in infants, penicillin in children, the multi-center trial of hydroxyurea, making sure you transfuse patients around surgery, a stroke prevention trial, and the institution of hydroxyurea even in newborn babies. So, but the last 15 years has seen an explosion in the area of beginning to look at new trials in sickle cell disease, which never existed before. So right now, apart from hydroxyurea, most of the people in this panel and the community are now aware there are new drugs like L-glutamine, crizanlizumab, voxelotor. So all these drugs are now coming into the market. And also in terms of trying to cure the disease, we've now established transplant from a fully matched sibling as a good way to cure the disease. Now we're beginning to dabble into less than a perfect match, who's a family member, and the results are pretty good. And Vanderbilt is pioneering the leadership in that area. And of course, gene therapy is really coming behind. So I think we're on the precipice of a new horizon for sickle cell disease. So if you look at some of these drugs, hydroxyurea, these are the approved drugs for sickle cell disease. Hydroxyurea, your L-glutamine, and also which is called Endari, and crizolizumab, which is called Adveco. And if you look at the outcomes, most of these drugs will reduce pain and acute chest syndrome. The other one that was also approved is called oxybrita or voxelotor, and that also has been shown to improve the overall hemoglobin of the patient, reduce pain episodes, and also affect acute chest syndrome. So all these drugs are beginning to have some impact, but there's still a lot of challenges. So the preponderance of evidence demonstrates that the use of hydroxyurea is associated with decreased morbidity and mortality when compared to no therapy. However, to impact mortality in sickle cell disease, we need to address the progressive organ dysfunction in adults. And one of the ways which I've been interested in over the last couple of years is actually the transplant from a family member, because we know that once you can get rid of the stem cells in the marrow that produces sickle cell, you pretty much change the whole milieu of the disease. Whether it's hemolysis, inflammation, all that changes. And this is a validated cure, not only in sickle cell disease. It's quite interesting that the first transplant for sickle cell disease, which was a success, was done in Memphis at St. Jude's. But now it's now becoming more available. And also in the horizon is gene therapy, where you actually look at targeted therapy for patients so that you are able to individualize therapy. This is still quite experimental. It hasn't gone into industrial scale yet. And we're still in a learning curve to see exactly what the long-term outlook with gene therapy will be. But the care of individuals starts with a proper diagnosis. Like I said before, you have to be able to distinguish sickle cell disease from sickle cell trait. So that requires a proper diagnosis. For those with traits, which really are a lot of our mothers and fathers and family members and siblings, these patients don't have anemia or hematologic consequences. They can have what you call hypostenuria, which is a defect in concentration within the kidney, or some hematuria. Occasionally, you see red blood cells if you look at their blood. They don't get pain crisis. Occasionally, they may get this if they go to high altitudes and get splenic infarct. We've seen an increased incidence of glaucoma with anterior chamber hemorrhage in some patients with trait. They normally have a normal lifespan, and we recommend genetic counseling should be considered for education and family counseling. There's been an hoopla about athletes with trait, where we talk about normal cardiopulmonary function with exercise. There's no adverse effects of chronic altitude exposure. Rate of trait in NFL, like general population. Rate of trait is higher in some Ivory Coast athletes, which is a place in Africa. Hemoconcentration due to hypostenuria has been seen in some athletes. No clear-cut relationship to sudden death. And it's unclear whether training will prevent heat-related consequences. So the recommendations for those with trait is there's no need for exercise limitations. We need to careful attention to dehydration accentuated by hypostenuria, acclimatize to heat and humidity, acclimatize to altitude, avoid exercise during febrile illness, be aware of heat-related signs. But, I'll just spend a minute or two on future public health challenges in sickle cell disease. One of the areas we're struggling with is the increased complications during transition. So it's quite clear that in our teenagers between 15 and 16 years of age, we see more complications after they've had a fabulous control in childhood, increase in pain and pulmonary. And this coincides with the period where they are out there on their own, they're rebellious sometimes, and they are kind of reacting against the system. So we need to pay more attention to them. And we realize there's also decreased intervention during this transition period. They miss transfusions, they're not compliant with medications. And this is not a phenomenon peculiar to sickle cell disease. We see the same phenomenon in young patients with cancer. So we need to direct some of our energy towards this area. People have talked about opioid being an epidemic and our patients are stigmatized. But if you look at some of the published literature a few years ago, it's quite clear that opioid-related death rate in sickle cell disease is substantially lower than any other disease areas. So this is not a problem in sickle cell disease. I think our patients are well managed, but it's unclear that they continue to get stigmatized, like they're the ones causing the opioid epidemic. And if you also look at the incidence data, especially from newborn screening, you will see here that sickle cell disease remains the most common inherited genetic disorder based on newborn screening database compared to pulmonary congenital hypothyroidism, cystic fibrosis, or combined phenylketonuria. However, if you look at the funding, there's a lot of funding inequality if you compare it to cystic fibrosis. This is not purely due to some of the racial disparity that persists in the society, but it also has to do with a lot of activism within the particular disease population, which is what I think we're beginning to clamp around. So this is now the time to address some of the care disparities in sickle cell disease. This will entail both academic as well as social activism. So we need to be able to control sickle cell disease better, providing best possible care for affected individuals, preventing the birth of severely affected individuals, newborn screening and use of prophylactic penicillin from birth to homozygotes, population screening and prospective genetic counseling, and availability of prenatal diagnosis and curative options such as bone marrow transplant or gene therapy or both. And of course, Michael is not here. He's been very academic. I work with him at Vanderbilt. He's been very active in terms of academic activism and was part of the brains behind the Sickle Cell Treatment Act, which was passed by the US Senate. And of course, what this has translated it into is Federal Sickle Cell Treatment Act of 2003, with funding for sickle cell disease centers in partnership with primary healthcare providers, federal match funds for sickle cell services. It allowed for nurses to be reimbursed for pre-conceptual genetic counseling in sickle cell disease. And the other important thing, especially for my physician panel, is we have to spend our energy, we're getting older, to mentor the next generation. So myself and Michael, we've spent time educating young doctors, especially young doctors of color. They have to know how to take care of sickle cell disease. We have to generate their interest. This is not something we just have to do and walk away. There has to be a continuum. This was a picture of some of our fellows going to ASH when we were actually going to present in areas of sickle cell disease. The other thing that is becoming critical is that the world is now becoming global. So what that means is we have an opportunity for what you call reverse innovation. Remember the epicenter of this disease in Africa? So there are clearly studies you cannot perform in the United States because you're limited in terms of number of patients with sickle cell disease. Being able to do translational studies that involves Africa allows you to be able to extrapolate some of those results to management of patients here in the continental United States. We need more infrastructure, what we call patient-centered medical home models in most areas, which can provide both pediatric and adult care, as well as all the ancillary services to address some of the chronic complications of the disease, as you can see in this slide. And what is most important is we need to remember what matters most to patients. So we tend to take patient surveys to let us know exactly what is important to them. It's not what is important to us. We've always partnered with Sickle Cell Foundation of Tennessee, developing partnership with local sickle cell disease associations. Also, we had instituted what is called Sickle Cell Sabbath with Mehari to be able to address blood donation drives within minority communities, educational sessions, improving trust, sickle cell trait testing, and promoting self-efficacy. So I think I'll stop there with this slide showing our community in Nashville and how we used to partner pre-COVID in order to support the community. So I thank you all for listening. I hope I'm just able to stimulate some people in the audience as to the work ahead of us. And I think we just need to keep the flame flying. Thank you.
Thank you, Dr. Kasim. A very, very good presentation. And we will have questions from the audience, as well as we have questions at the end of this particular panel session. For those individuals who are listening, if you have questions, please go to the comment section of the YouTube and put your questions in there, and we will retrieve those questions and entertain them at the end of the program. At this time, we'll move on to our next panelist. Our next panelist, who I earlier introduced, is Dr. Richard L. Martin. Dr. Martin serves as the medical director at Meharry Medical College, and Dr. Martin will discuss this morning COVID-19 health disparities, as well as solutions in achieving health equity in sickle cell disease. Good morning, Dr. Martin, and thank you for joining us.
Yes, thank you. Thank you to the panelists and being able to be a part of this. And I actually consider myself one of Dr. Kasim's mentees as he was finishing up there, talking about passing the torch to new physicians. And in many ways, I see myself as a partner with a lot of what was just discussed. You know, we are now at a time and a place where we understand this disease well enough to create some potential permanent cures. And we'll talk a bit about those technologies via CRISPR or haplotransplant. So we have these things. And now the question is really, do we have the willpower? Do we have the community engagement, the global engagement to ensure that patient populations, notably with historical disenfranchisement, and devalued of their own medical illnesses, do we have the willpower to achieve universal access to these new discoveries? And that's where I see my role and Meharry in partnering with the community. And I think, you know, it's one thing to just say access, but I think as Dr. Kasim brought up, another thing that we all need to do a better job with in our communities, but also nationally and globally, is the stigma behind this disease. And that's where I discuss the community engagement piece, because sickle cell disease, while it has many other disparities, which are true of the way we care for our Black and brown people in this country, sickle cell disease also has some unique disparities, which aren't even about access, but often are due to cultural mistreatment. Words like sickler get thrown around to people, which, you know, in my opinion, has some kind of racist tropes underlying that epithet. And then we also stigmatize people, as Dr. Kasim said, for using opioids, when data says that it's actually quite a safe medicine to use appropriately in our sickle cell population. And so when folks end up in the emergency room or have an unfilled prescription because our medical system failed them, I think too often we rush to blame our patients, or the medical system rushes to blame the patients. So I'm very excited to get to be here today to just communicate that I think this is the beginning of a new era in this 21st century where we have these tools, and now we really need to figure out how we work together, how we come together to provide access, listen to our patients, provide culturally respectful patient-centered treatments, and collaborate within the community, recognizing that I don't have some of these tools, but in our partnerships with the folks at Vanderbilt, Sarah Cannon, Belmont, and the broader community, churches, school systems, that together we can truly deliver exceptional care to our patients with sickle cell disease.
Thank you. Thank you, Dr. Martin, for the presentation. And once again, prior to moving to our next panelist, once again, if you have questions from the audience, please put those questions in the comments section of the YouTube, and we will answer those questions, or if we don't get a chance to answer them, we will respond to them. But we do have some time at the end of the program to address questions. Our next panelist is Dr. Lamitra Scott, who is a PharmD. Dr. Scott is the founder of Breaking the Sickle Cell Cycle. Good morning, Dr. Scott. How are you?
Good morning, Mr. French. I'm doing well, and good morning to all of the panelists here. You all have done such a great job of explaining exactly what sickle cell disease is, how it affects so many people, either directly or indirectly, and also highlighting on the disparities that are contributing to the negative aspects or the negative outcomes that sickle cell patients ultimately face. To piggyback off of Dr. Martin in terms of looking at disparities that occur in the community and what we can do overall within the sickle cell community to try to change the phase of how sickle cell disease affects patients. One thing we can do, and I know with Dr. Kasim and Dr. Devon, is change the terminology in terms of how we view sickle cell disease. Oftentimes people refer to sickle cell disease or when they're having a pain as a crisis. Crisis implies that there is nothing that you can do individually or personally to help control the situation. But if we turn that around and we continue to refer to them as sickle cell pain episodes, and episodes puts a definitive time on it. You may be experiencing pain, but there are things that can be done that limits that pain or controls it for that particular point in time. So I think starting there in terms of how we refer to sickle cell disease, sickle cell pain, I think will ultimately begin to change the course of how patients are able to be empowered. Another way that patients can be empowered is through medications. Dr. Kasim highlighted on some of the medications that are utilized to help manage sickle cell disease, and that's basically what I will talk about during my session. So last year in 2019, there were two medications that came to market. They were Adakveo and Oxbryta. Adakveo, crizanlizumab, and Oxbryta, is voxelotor. That's the generic name of it. So both of these medications are what you would call novel in the way in which they affect and treat sickle cell disease. So crizanlizumab or Adakveo, this is actually an IV infusion that actually helps to decrease pain because it actually blocks the blood vessels from clogging up together. And it does that by interfering with the blood vessel protein that's expressed on the inside of the blood vessel wall. It interferes with the protein that's actually responsible for those blood cells collecting together to actually form those blockages. Oxbryta, it has a unique mechanism in that it actually stops the blood cells from sickling in the very beginning. In Dr. Kasim's presentation, he talked about how hemoglobin S is responsible for sickling, and under deoxygenated conditions, that means that when the oxygen is removed from the red blood cell, those cells begin to elongate and turn into that crescent form, sickle as we refer to it as. Oxbryta actually stops that process from the very beginning. Prior to those two medications coming to market, we have hydroxyurea and then we had Endari. Well, hydroxyurea, it actually works to help increase the hemoglobin F content. Hemoglobin F is the type of hemoglobin that is expressed during the fetal time period. And because it has a different subunit, instead of having an alpha and a beta subunit like hemoglobin S, it actually has an alpha and a gamma subunit. That particular change in subunits that make up that particular hemoglobin are what make it unique in that it does not sickle. So hydroxyurea was what we consider, or still is what we consider, the mainstay of treatment for sickle cell disease. And by increasing that hemoglobin F content, it was shown that there were decreases in vaso-occlusive episodes, there were decreases in the rate of acute chest syndrome, decreases in the risk of stroke, and also decreases in the need for blood transfusions. So that is why hydroxyurea became to be the standard of care, because of all of the benefits that it provided. The downside of hydroxyurea is that it does cause myelosuppression. What that means is that it causes the cells of the immune system to decrease in their ability to function and in their ability to be produced. But that can be controlled when you have a medical team that is looking at the laboratory work, looking at the blood cells to determine what is the right dose for a particular patient. In addition to that, there were some adherence issues with the hydroxyurea in terms of patients adequately taking the medication appropriately as they should. And on top of that, what we've seen is that there is an underutilization of hydroxyurea within the sickle cell community. So there were a lot of challenges around hydroxyurea and its use, which led to more innovative therapies, what we have with Endari, which came on the market in 2017. Endari is an oral powdered form medication That is L-glutamine. It's an amino acid. You may oftentimes hear or see L-glutamine in your nutritional shops or places like GNC, but it's important to remember that the L-glutamine that you find in your nutritional shops is not the same L-glutamine that is contained within Indari. The concentration is significantly higher, which is the reason why it's by prescription. So the way that Indari works is that it actually performs as an antioxidant. What that means is that it actually protects the red blood cells or stabilizes the red blood cells so that they aren't as fragile. This is important because when red blood cells break down, or what we call hemolyze or hemolysis, when those cells break down, the intracellular contents that are released, they actually affect all the other cells that are around it, and actually cause those other cells to form or undergo hemolysis. That sparks an inflammatory reaction within the body. That inflammatory reaction, it brings out more cells to come to try to fix what the problem is that's going on in your body. Remember, sickle cells are very sticky. They're very hard. So when those inflammatory cells come to try to fix what's going on within the body, they increase the likelihood of forming a blood clot. So all of those medications, Indari, Adacthio, and Oxbryta, they all help to decrease vaso-occlusive episodes or decreasing the risk of blood clots from forming. In addition, hemoglobin levels are increased with Oxbryta and with hydroxyurea. This is very important because, as Dr. Kasim pointed out in his presentation, sickle cell disease is not only about pain. Sickle cell disease is a disease that affects the entire body. So anytime we are able to increase the level of hemoglobin, that has actually been shown to decrease multicellular organ failure and improve outcomes just by increasing the hemoglobin levels by increments of at least one. And every time that number goes up by one, you increase the chances of decreasing organ failure and death. So in talking about all of the new medications that are available, the efficacy rate is about 40% for all of them with the exception of Indari, in terms of decreasing vaso-occlusive episodes. And for Indari, the rate of reducing vaso-occlusive episodes runs about 25%. So if you look at it in terms of improving your quality of life, there a 40% reduction in the number of pain episodes that you experience within a year, that could be life-changing because that's one more day or a couple more days that you get to go to work. You don't miss work. Okay, you don't miss work. You don't miss school. So there are options and tools available for you to use when you have sickle cell disease, but you have to, one, know that they're available and how to access them.
Thank you, Dr. Scott. A very good presentation that Dr. Scott gave us on the treatments and the medications regarding sickle cell disease. And once again, at the end of the presentation, we will open it up for additional questions. We now will proceed to our next panel. Our next panel will consist of a very, very important group of individuals, patients, caregivers, as well as the provider panel. So at this time, I would like to introduce the individuals who are serving on this particular panel today. We have our co-host, Ms. Kiara Moore, who is the Health and Wellness Ministry Coordinator, once again, at Mount Zion Baptist Church, Nashville. We have Alexis Gordon, who serves as the State Director for the Sickle Cell Foundation of Tennessee. And we have Dr. Maria del Pilar Aguinagua, who is from Harry Medical College. Good morning, Ms. Young. How are you today?
Fine. How are you?
We're doing well. First of all, I'd like to thank you all for serving as a co-host for such an important program. And we sincerely appreciate Bishop Walker opening up the doors of the church and being so gracious to participate on today. And thank you for all that you've done thus far.
Absolutely. Absolutely.
So now I'd like to give you an opportunity. As I indicated, you are a co-host, but you also are a caregiver. So I'll give you an opportunity to talk about sickle cell and how it has affected your life, and how do you see the intersection of the faith community and sickle cell disease?
Yes. So as you mentioned, I am the Health and Wellness Coordinator at Mount Zion in Nashville, Tennessee. My sole purpose and my role is to implement programming to educate and bring awareness to various health issues that affect our communities. My role acts as an inreach role and outreach. And so all of our programming, we use it to target not only our members, but also those in our community to educate them and bring resources to them as well. And in my role as a caregiver, and so actually earlier this year, my newborn daughter was diagnosed with sickle cell disease, SC to be exact. And I was always aware of my trait status because the trait is very prevalent in my family. So my mom has the trait, all of my brothers, grandma, aunts, uncles. And so we were always aware that me, as well as my brothers, younger brothers, have the sickle cell trait. And so when I got married, started having kids, we thought that we were aware of my husband's trait as well. But my son, he was born, we were told that he had the trait, which we were expecting. Then after my daughter was born in March, we were told that she had sickle cell disease. And so we were very confused with how, that happened. And then with some more research, some more tests, it was discovered that my husband actually has the C trait, which is a less common trait that is found. And so hence my daughter being diagnosed with sickle cell disease. Although we're very early on in our journey through sickle cell disease and, the doctor visits and all of that, just from what I know personally as a public health professional and from what I've seen, it's very clear that there is a need for more advocacy, more funding, more education around this disease. A lot of people are unaware of their trait status. And then even in my situation, we thought we knew our trait status, but my husband was misdiagnosed. And so there's just more education, more funding, more advocacy that's needed so that people are just aware of what's going on, particularly when it comes to when you start having kids and things like that, just so that early treatment interventions can be done. We're very, very thankful for our team at Vanderbilt. They've been awesome so far. And we're on the front lines, not only as a public health professional, but also as a caregiver to make sure that as we continue, that the issues that most sickle cell patients have to deal with now, they won't have to deal with in the future.
Thank you very much. We sincerely appreciate that. And we will entertain questions at the end of the program as well. Our next panelist is Ms. Alexis Gordon. Alexis served as the state director for the Sickle Cell Foundation of Tennessee, and Alexis also lives with sickle cell disease. Good morning, Alexis. How are you?
Good morning, Reginald. I am great. How are you?
Good morning, and thank you for participating on this very important panel as well. So I'll give you an opportunity to talk about, whatever you want to say, essentially, if you want to talk about from the foundation perspective or as well as from the transition from childhood to adulthood and living with sickle cell disease, but the floor is yours.
Thank you. And good morning to everyone. I will focus my discussions or my information on adults living with sickle cell disease. Many of my lifelong, I call them sickle cell disease survival traits, were instilled in me by my parents in my youth and in my teenage years. My parents were sticklers of faith, education, and self-advocacy. They taught me to learn my body. They taught me to identify triggers, which I carried through adulthood. So as a young adult in college, I basically had documented instructions from my hematologist and PCP, my primary care physician at that time, to provide to the on-campus clinic, if you will, the hospital emergency department, if I had to go there, in case I had a pain episode. Self-advocating and spreading awareness about sickle cell disease have carried into my adulthood from then. Did I have pain episodes in college? Absolutely, sure. But I was taught early on what to do, when to seek help, and learning the triggers that could negatively affect my sickle cell disease. Fast forward to marriage and childbearing. I was blessed to give birth to two miracle babies who I call heartbeat number 1 and heartbeat number 2. At that time, I spoke with my OBGYN about my disease and about my childbearing goals. She partnered with me at that time to learn and to research how to have children safely and to manage the triggers of sickle cell disease. One of the things about sickle cell disease is that for me, it expanded my pain threshold, so much so to the point that I was unable to recognize labor pains. So this is something that I talked about a lot with my OBGYN, because for me, labor pains were less strenuous than my sickle cell disease pain. Again, learning my body through adulthood, so much so that my first child, when I got to the hospital, I was already ready to give birth and didn't even know it. But as an adult, I have been able to establish a career while managing my sickle cell disease. Again, learning my body, managing the triggers, and self-advocating for myself. I also know that there are several adults, though, that live with sickle cell disease who are unable to maintain employment due to issues with sickle cell disease. So I advise them to self-advocate, learn different trades, learn to be self-employed in order to have a living as an adult living with sickle cell disease. Currently, I'm just continuing to manage the triggers by reducing stress, staying weather aware, trying to live as healthy as possible, which includes eating, exercise, preventative medications, regular contact with my sickle cell disease physician team, which includes Dr. Kasim, as well as keeping up with my medical appointments. So I hope that gives you a little bit of perspective into my life living with sickle cell disease as an adult.
It did. And thank you very much, Alexis. And we'll come back to you during the end of the program for questions. Our next panelist is Dr. Maria del Pilar Aguinaga. I should have pronounced her name because I talked to her probably 3 or 4 times a week at Meharry. Meharry is one of, such as Vanderbilt, one of our strategic partners who we work with on a daily basis, and we speak to throughout the week. But good morning, Dr. Aguinaga, and thank you for joining us this morning as well.
Good morning, Mr. French, and good morning, members of the panel and the audience. I am Dr. Aguinaga, professor in OBGYN and director of the Meharry Sickle Cell Center. I came to Meharry as a postdoctoral fellow and rose through the ranks through tenure professor. I have spent my entire career at Meharry Medical College educating minorities to become physicians, dentists, scientists, and public health practitioners. Most of our medical graduates go to practice medicine to underprivileged and underserved population, promoting health equity among these populations. And as we know, there are health disparities in sickle cell and in other diseases that primarily affect minorities, that affect us. My work at the Sickle Cell Center is to oversee the confirmatory and reference lab for hemoglobinopathies for the state of Tennessee Department of Health newborn screening program, which has been housed at the Meharry Sickle Cell Center since 1989. Our mission is to improve the quality of life and extend the years of life of individuals affected with hemoglobinopathies by providing early confirmatory testing, follow-up, treatment, education, and counseling to families affected with these disorders. Also, to promote community awareness of hemoglobinopathies by conducting community screenings and educational activities in the state of Tennessee. The Meharry Sickle Cell Center is a partner of the Vanderbilt Meharry Matthew Walker Center of Excellence for Sickle Cell Disease that operates a medical home from cradle to rocking chair for sickle cell patients in Middle Tennessee. And I am thrilled to be part of this panel today and looking forward to an exciting discussion in sickle cell. And thank you very much for having me.
Thank you as well, Dr. Aguinaldo. During this session, we do have time for one of the pre-questions that we initially had put together. So, and this question is open for any particular panelist, but maybe more so to you, Ms. Moore, or anyone can address it. You know, a lot of times we talk about those individuals who are living with a rare disease such as sickle cell disease, but caregivers play a very, very vital role in everything that you do. I mean, from the parents to the sisters to the brothers, people responsible for transporting back into the hospital. But can someone address the role of caregivers in dealing with sickle cell disease? And is it any different than any other illness that exists with individuals?
I'll start because, as you all know, everybody on the panel knows that I have a son. He's 8 now, and he has sickle cell disease. And for me, we found out that he had sickle cell disease kind of haphazardly because he was misdiagnosed. Initially, I was told by his pediatrician that my son did not have sickle cell disease, that he only had trait. Well, because of the newborn screenings that are done and the follow-up that is conducted by the state of Tennessee, I was quickly informed that my son does have SS and that we needed to bring him in and get him connected to the hematology team over at Vanderbilt so that we could control what was going on and to get on the right path to prevent future negative outcomes with sickle cell disease. So when you talk about going from 0 to 100 in the matter of a phone call, that's exactly what happened in life, and it got flipped upside down on its head. Because I was not aware that I was a sickle cell trait carrier. We were not aware that my son's father was a sickle cell trait carrier. So we are literally almost like in the middle of a storm. So what do you do with that? For me, I decided to take all that negative energy of what could be and turn it into something positive. And that is how Breaking the Sickle Cell Cycle Foundation was born, because I wanted to create an avenue where I could use the information that I have as being a healthcare provider and also being a sickle cell trait carrier myself. What could I do with that information to try to help other people that are walking this path? How can I educate them? How can I inform them that things are not all bad? Because when you think about sickle cell disease, the first thing you think about is pain, hospitalizations, and death. That's just pretty much the summation of it. But it's so much more than that. And you can have a positive life, a positive outlook, if you educate yourself appropriately. And that same education that you have as a caregiver, that rolls over to your child as well. If you are in control of your child's situations, and if you are in control of your emotions, then your child picks up on those same traits and they're able to carry those things with them throughout their life. So I would say, as a caregiver, educating yourself, preparing yourself, and also sharing that information with other caretakers, with other people that may be in the school system where your child may go, whoever may have a hand in being responsible for your child's care, they need to know, if not as much information as you do about sickle cell disease, but at least the basics or the fundamentals, educating yourself and others about sickle cell disease. I think as a caretaker, that will help you be empowered to handle the situation, and therefore positive outcomes can come from everyone around.
Thank you very much. I appreciate that. I'm glad I asked about the important role of caregivers, which plays a vital role. And you just, explain as a mother how it has been, a challenge, but as well as a rewarding effect for you. At this time, I'll move to our next panel, which is a very, very important panel. Dr. Kasim Counter lightly articulated on the importance of advocacy, but we'll deal more with that on this particular panel. This panel is the public policy panel. This panel, the individuals on this panel is once again, State Representative Dr. Harold M. Love Jr. He represents District 58 in Nashville. Mr. Howard A. Mosby, who is a Georgia Safety Hospital Administrator, a member of the Georgia House of Representatives for 16 years, and he's also on the board as well as the board treasurer for Hill Collaborative, who is serving as one of our sponsors on today, as well as we have Dr. Lamitra Scott. Good morning to each one of you all.
Good morning.
Morning.
Good morning. Representative Love, we'd like to start with you. One of the things that Dr. Kasim initially, he mentioned in his in his speak, he talked about two things that I think that we can talk about this morning. He talked about the funding mechanism as relates to the disparity, as relates to sickle cell disease in comparison to other rare diseases or other diseases as a whole. And then secondly, he talked about advocacy. And when he said that, that's something I've always felt in my involvement on a daily basis. I think that the advocacy piece has to be heightened a lot more. So there's, without a doubt, there's a correlation between the funding. Obviously, it could be a correlation from a racial aspect too, but without a doubt, there's a correlation between the funding as well as how sickle cell is not receiving the funding from a federal level, from a state level. But can you just talk about, as a policymaker, what do you think that we can do, as well as your involvement with sickle cell disease from an elected standpoint?
Thank you. And that is a very important question. And I'd like to just give a very basic and very quick overview of the importance of civic and public engagement. Oftentimes we talk about the need to go out and to cast a vote, but Brother Mosby knows, having served in the Georgia House, that voting is just one part of what we call the electoral or public engagement process. It's not enough just to go cast a vote and then go back to not engaging. It's about attending town halls. It's about attending council meetings in your city. It's about attending committee meetings in your state legislature. It's about reaching out to your elected congressperson and U.S. Senate on a federal level, because it's about engaging elected officials who control the budget process and also control the process when it comes to indicating what particular diseases will be reimbursed by Medicaid. And that's very important for, I think, our listeners to hear. And that's why I think it's so very important for us to talk about engagement, because you have to stay engaged. And oftentimes people will say, well, listen, I don't want to get political. I don't want to get involved in government. I remind people that in order for you to be legally recognized as being born in this country, you must receive a birth certificate. And unfortunately, for you to legally be dead in this country, you must receive a death certificate. And both of those are issued by governmental agencies, which means that really government brackets your life from birth to death, and in between everything else that goes on. And so people must be engaged. People must reach out to their elected officials and talk about the budget. And I oftentimes refer to the budget as a moral document, because in that budget is what we care about. In that budget is what we deem to be a priority. In that budget is what we deem to be important. And so if you don't see funding for sickle cell in your state or city or federal budget, then that means that the policymakers don't think that it's important. And so I would just a brief, understanding of civics from that perspective. Now, for my role in getting involved, I must give credit to Dr. Michael DeBond, who came to me several years back and said, Representative Love, we need your help, because we've just gotten this federal bill passed that allows for sickle cell to be put into a certain category to have it be a reimbursed treatment. And I said, well, what does that mean, doc? He said, well, what it means is that ordinarily a patient cannot go to see their doctor in the office for a regular routine doctor's visit unless Medicaid is going to reimburse them, if they're on a Medicaid program. And said up until that point, sickle cell patients could only really go to the emergency room or to the hospital to be treated, because they would be considered uncompensated care or uninsured persons and be treated in that formula. But what the federal government did was classified sickle cell as one of those treatments that could be put into a Medicaid reimbursement program. Mm-hmm. When they passed at the federal level, each state then had to put it on its list in their state of what type of diseases could be treated, so that doctors who had patients on TennCare, which is our Medicaid program, could get reimbursed. And so I was grateful to Dr. DeBond to explain it to me, and humbled to be able to sponsor the legislation and get it passed. that now allows not just patients to see their doctors, which is very important, in their doctor's offices if they're covered by TennCare, but to also have TennCare, our Medicaid program, engage in preventive programs. I heard someone mention the testing for sickle cell trait versus sickle cell disease, and we have to ramp up our testing to make sure that we do test not just for the disease, but also for the trait, to make sure that persons can have those understandings when they go into relationship with folks and know you might potentially have a child that has a disease because both the husband and wife have the trait.
Thank you very much for that information. One of the things that we know about you, that you have been an advocate for sickle cell disease, as you just said, for a long period of time, and you're still one. And we sincerely appreciate all your support. Our foundation is very grateful for everything that you do, and I'm certain that the full sickle cell community throughout the state is. And thank you very much. And we'll come back to questions. Mr. Mosby, as a former Georgia legislator, as well as chairman of the Georgia Black Caucus, your involvement in sickle cell disease has been just enormous for a long period of time. Tell us about, what do you see that we can do more so from an advocacy standpoint to keep the disease at the forefront and get the community more engaged?
Thank you, Reginald, for that. And I'd like to thank Brother Love for the work that he's doing in Tennessee. It is yeoman's work, and people really don't understand how hard it is to actually move legislation through a legislative body, and it takes the type of commitment and respect that he has garnered in his General Assembly, and you all need to continue to support him. For us, so we started HEAL Collaborative. When I stepped out of the legislature, one of the things that I was able to see clearly was that policy, when you look at the social determinants of health and health equity, that there is this gap, and you see that policy is made in one space, and then policy is administered in the healthcare space in another place, and then there's this gap that happens. And so therefore, there must be some translational error that's happening in this process. And we started this organization actually to try to help advocacy groups learn how to advocate in these legislative bodies. And we also wanted to educate legislators to understand what the advocacy groups and patient caregivers and patients were receiving under these policies that were being made. It is extremely important for individuals to be involved in this process. Representative Love just kind of outlined it perfectly. And if you're not at the table, you're on the menu. And in a lot of different ways, our community is virtually unseen in these capitals, in these state capitals, as policies are being made. He's absolutely correct. The budget is a moral document. It's just like your checkbook. It determines this process. You put your Representative Love, just money is being spent. And in a lot of ways, we have to advocate strongly for those things that move the needle in our community. And sickle cell is huge, but it's just not sickle cell. When you start looking at how Medicaid dollars are spent, because many people in our community don't have access to commercial insurance. And as Representative Love said, federal government passed the law to allow for Medicaid to pay for this, but you have to get your state now engaged in this. And to me, that's a moral step that shouldn't happen. But guess what? We're here today, and we're here to make a difference. And bringing all these disparate groups together to actually have this conversation is a great way for us to solve this.
Thank you very much, Mr. Mosby, for those comments. The next panelist is Dr. Scott. Dr. Scott, Dr. Love has already kind of talked about Medicaid and how it intersects with sickle cell disease. But as a pharmacist, do you see any barriers for sickle cell patients that currently exist now that we may need to be aware of, in particular as relates to the two new medications that you discussed previously?
Thank you, Mr. French and Mr. Love and Mr. Mosby, for all of your comments, because we need everyone acting collectively, of course, to move the needle in terms of how outcomes and patients with sickle cell disease are treated within our healthcare system. From a pharmaceutical perspective, there are significant barriers to access. So while it's been over 100 years since sickle cell disease was discovered back in 1910 to where we are today, and we have a handful, literally, of treatments that are available. But just because those treatments are available does not mean they're readily accessible. They're not readily accessible because of the managed care plans and how they choose to prioritize them, as Mr. Mosby stated, in terms of how they choose to cover them. So while these medications are available, and if patients don't know the proper steps and channels that need to be navigated through, then you still end up without on the back end. So with the new medications, Endari, Adakveo, Oxbryta, those medications, fortunately, under the TennCare Medicaid plan, they are available, but they oftentimes will require what's called a prior authorization. That means the provider must submit medical documentation as to why a patient with sickle cell disease needs said therapy. Many patients, if they don't understand that, or if they don't even know that the medications are available, then getting a prescription for a medication is only half the battle. When you get to the pharmacy counter and you find out that it's not covered, you still have negative or no treatment that's effective for your sickle cell disease. So, in my opinion, what could be done from a managed care standpoint is to make more medications readily available without so much red tape. Now, because these medications are connected to severe side effects like myelosuppression in terms of hydroxyurea or adverse outcomes that could occur if blood levels aren't monitored appropriately, there's a rationale for why these things need to be monitored. But in terms of access, I know that from the managed care standpoint, they're trying to control their budget as well. And these medications, they're not cheap by any means. So that's a means of the managed care organization controlling costs. But at the end of the day, who pays for that? The patient does. So I would just advocate from a CMS standpoint overall that there be more inclusion into medication formularies when it comes down to treating sickle cell patients. Because at this point in time, is not as vast as it should be, in my opinion.
Thank you very much. I would appreciate you discussing it from a Medicaid standpoint. Now we come to a very important part of the show. We've asked the audience, if you have any questions, please put your questions on the YouTube channel, and we will actually download those. And thus far, we have a lot of people participating all across the country. I see Georgia, I see South Carolina, Tennessee. So let me first start with a couple questions. And I think the first two may be directed towards their physician questions. And it's up to any doctor to discuss it. On 60 Minutes, there was a good, thorough special dealing with sickle cell disease, and it was related to gene therapy using CRISPR. Can someone explain to us a little more thoroughly to the audience, what is gene therapy? On 60 Minutes, there was
Yeah, I can take that. So if you look at the biology of the disease, whereby affected patient inherits these abnormal proteins from both parents that come together to form the disease. So that's really the tip of the iceberg. The question, and of course, cascading from that is the fact that these proteins are abnormal. The best way to understand what gene therapy is trying to do is when a child is born with sickle cell disease today, they really don't manifest the disease until about 6 months. And that coincides usually with when what you call the baby's hemoglobin or fetal hemoglobin begins to wane, which the baby has in the womb and has what you call a high fetal hemoglobin. And what that does is it allows the baby to take oxygen from the mother, whether she likes it or not. So for the baby to survive. So we realize that the reason a child, when they're born, even though the heel prick that Dr. Aguinaga does will say, oh, this patient may have sickle cell disease, but they don't really manifest symptoms till 6 months, is because that fetal hemoglobin protects them. But once that fetal hemoglobin disappears, then they begin to show the full complement they inherit from both parents. And that's when they begin to manifest the disease. So what CRISPR is trying to do is what Hydra is doing on steroids. So what they're doing is saying, and normally when the child hits 6 months, just naturally the fetal hemoglobin is suppressed and what is inherited from both parents go up. So what you get there is CRISPR is trying to silence those proteins that produce the sickle cell while increasing the production of that fetal hemoglobin that you get in the womb. So that is what CRISPR is doing. And so normally we will have probably 1-2% fetal hemoglobin in a normal adult without sickle cell disease. But with CRISPR, especially when you upregulate that fetal hemoglobin, it goes to 30, 40, 50%. What we don't know is after that gene therapy, if that fetal hemoglobin is high, is that going to be protective for the next 50 years? Nobody right now can give you that answer. Now, the other option is to actually what people must have heard called the viral reintegration, whereby they use a virus similar to the HIV virus to kind of use that to infect the patient's stem cells that they've collected to sort of correct that defective gene so you don't produce sickle cell again and insert what you call normal hemoglobin into the gene and then give that back to the patient so that they can continue production. Again, only time is going to tell whether once that is done, that virus integration into the gene doesn't cause other problems 10, 20 years from now, but the early results are very encouraging. And two, whether that is going to be sustained, because you have to have that sustained production of normal hemoglobin for the rest of your life. So only time is going to tell, which is very different from transplant in which you just literally get rid of your stem cells and you put one from your brother or sibling fresh into it.
Thank you very much, Dr. Kassim. Just from a time perspective, it is now 11:15 Central Standard Time. We have 15 minutes prior to closing of the program. We have several questions. The next question is directed to whomever may want to answer it. As people with sickle cell disease get older, should they be concerned about organ failure?
I'll take this one. And very quickly, I just want to say Ms. Scott, Ms. Gordon, Ms. Moore are the real heroes. And I'm just amazed by listening to people's stories. And Representative Love and Representative Mosby, who called us to action so we can continue to build agency. It's through meetings like this that we're able to come together as a community, make our voices louder, more powerful, so that we can ask for greater justice, equity for folks with sickle cell disease. To the question about organ failure getting older, yeah, the name of the game in this disease is about early identification and giving people the tools and strategies to keep their disease under control to prevent that long-term damage. Now, that being said, as we get older, even under the best control, there is a potential for organ damage. Some of these things tragically, neurologic damage, cardiac damage, renal damage, these things can be irreversible. So it can be about slowing it, identifying it. There are other medications that can help and other therapies that can help support when we do identify whether it is neurologic, renal, we can slow those processes down. But identifying this, getting people on treatment, getting them access, getting them, the community services that they need, all of that is the best way to go about it. And so for a lot of folks who don't have that comprehensive care or that full support, things like retinal exams on an annual basis, these things can go kind of lost in the shuffle. And so it's so important to get engaged, to make sure that you have a community that understands this disease, because prevention is the most important step. And then I think it looks like there's a follow-up question, so I'll let my colleagues discuss that further.
It looks like her question says, what can churches do to support SCD patients and families? I'll speak to that one because in partnership with Mount Zion, during the month of September, I have conducted sickle cell trait testing. So it starts there with notifying the community about their sickle cell trait status. That is something that is monumental and life-changing, generation-changing. If you can help a person identify whether or not they carry the trait for sickle cell disease. In addition to that, I've worked with Kiara in conducting the back to school community outreach day is another place where we just go out into the community. So even for people that are not members of the Mount Zion Church, by providing them services in the community to provide that sickle cell trait testing amongst a host of other things that are necessary for back to school drives. That is another opportunity to engage people that you may not always see and then educate them about sickle cell disease. So the best thing that any church, no matter where you're located, can do, in my opinion, is to foster and take ownership of educating the community. I think that if we have more support from our faith-based communities in acknowledging that sickle cell disease is something that affects our communities more so than others, and providing them with that source of reliable education information, I think that is laying the foundation for improving the lives of those affected by sickle cell disease and those who may potentially, need help with family planning. That's information that could be useful for them. I'll let Kiara speak more to that degree.
Yes, absolutely. Everything you you just said. And thank you for allowing us to partner with you in those initiatives, because trait testing is so important, particularly when it comes to family planning. And I think particularly in my role, and then just the role of the church in general, we're the center stones of our communities across the country, not just here in Tennessee. And so from what we've seen, particularly with African Americans, if it's coming from your church, it's more accepted, it's received better. And so educating across the host of health issues has really been able to allow us to get past a lot of the cultural things that we deal with, a lot of the historical aspects of health that a lot of folks in our communities are apprehensive of. The role of the church is vital to helping to combat some of these issues.
If I might add a little bit to that piece, I'm in my 21st year of pastoring now. And what I realized is that the church has this issue with discussing a lot of things around sex and birth. And we got to get to the place we can discuss things like infant mortality, maternal mortality, sickle cell, right? All those things. And that's where we bring those walls down so we can have a conversation about, getting tested for everything. I think once we do that, our faith-based institutions are better equipped to remain the center of our communities and allow persons who may not be part of that community to come in and say, listen, I want to get tested at your back to school event. I want to come by if you have a testing at your church. Or ask the question, how many of our faith-based institutions are having internal conversation with their members about these issues? I think that's where we got to start also.
I couldn't echo better Representative Love, Dr. Scott, and Ms. Moore on the importance of trait testing. And also with testing, it comes education. Both go hand in hand. The Meharry Sickle Cell Center conducts regularly community screenings in collaboration with our partners, like the Breaking the SS Cycle Foundation. We have conducted several testings at Mount Zion at the different locations. And also, we must remember one particular thing, especially in Middle Tennessee, that the face of sickle cell disease is changing. We have a large number of immigrants. We have refugees and immigrants. We have people from Central South America, people of Mediterranean descent, a lot of people of Arabian descent, people from Kurdistan, from Iraqi population. And we must not forget this. And we have conducted screenings and educational sessions also at Hispanic churches and in many African American churches. And at Hispanic churches, we need to raise awareness about sickle cell because Hispanics do carry the trait, not in such a large prevalence as African Americans, but they do carry the trait. And we have several families affected with sickle cell disease. And this also implies that we have to develop culturally competent and linguistically appropriate educational tools to access these communities. So the role of the churches is crucial to reach out to the population to promote testing and promote education in sickle cell. Thank you.
Thank you very much.
Well, can I jump in here right quick?
Sure, go ahead, Hal. Absolutely. Yeah. Please do so.
And it's real quick. And everything that we're talking about today is why HEAL exists. And the church is, as Dr. Scott said, as the cornerstone of our community. And we are wanting to do more of these kinds of conversations across the board because it is absolutely necessary. And then we can work with concentric groups away from the church. But the church is the most integral piece of that puzzle in getting this out. So I just want to make sure we said that.
Thank you very much. Well, we're now about 5 to 6 minutes prior to closing out, and prior to giving each panelist an opportunity to give closing remarks, I need to once again thank our co-host, Mount Zion Baptist Church, for your assistance in putting this on. This has been a monumental task, and we sincerely appreciate the church participating. I also need to thank the sponsors. We could not have did this without the sponsors coming forth and playing a vital role in this. I need to thank HEAL Collaborative along with CRISPR as well as Vertex. Thank you so much for all that you all have done to make this an amazing day. At this time, each panelist will be giving 1 minute or maybe a little less than 1 minute to give closing remarks on what you would like to say. And I'd like to start with Alexis, since we haven't heard from her in a period of time. Alexis, if you can start off, please.
Hi, yeah, I'm here. Thanks. I appreciate the opportunity to share my story. Thank you for everyone who has been on this panel and has shared information. I am pleased to continue the work that I've been doing with the Sickle Cell Foundation of Tennessee, as well as in the community and really across the nation with finding a cure for sickle cell disease. Again, I want to emphasize to the adults who are watching that living with sickle cell disease is a challenge, but it can be managed, managing our triggers, learning and becoming more familiar with our bodies and managing those stressors and being able to maintain a healthy life and living to the fulfillment that God gives you. So I appreciate the opportunity to share and thank you all again.
The next panelist, you could just go around the table. Whomever wants. Okay, absolutely. Miss Young.
Yes. Yes, I'm so happy that I was able to be a part of this. It's been a joy working with all of you, particularly HEAL. Thanks so much for reaching out to us. Mount Zion realizes its role in the community, not just for our members, but for those around us, particularly pertaining to health issues. And as a caregiver of someone with sickle cell, although new, being a part of this definitely has been educational for me. It definitely gives me hope for my little baby girl that one day, she'll be able to grow up and be successful and healthy and live a long and joyous life with sickle cell. And so that's been really empowering for me through this. And so I'm super excited to continue my work as a health professional and as a caregiver.
Thank you very much. Dr. Moore. Excuse me, Dr. Martin.
Great, and thanks again for allowing me to speak on this panel with so many amazing people. I think what I'd like to get out of this panel and moving forward is that we change fear, apprehension, distrust into hope and empowerment. And above all, from my perspective as medical director on the clinical side at Meharry, I just want you to know that we're listening. So when you folks in your churches are speaking about these issues, wondering, should I get tested? How do we get trait testing? And you actually get that test, you know that there's somebody out there in the community that supports you, and that we are collectively building a partnership to support you, not just through your medical needs, but I think as, again, Ms. Gordon, Dr. Scott, Ms. Moore spoke to, the impact this disease can have on relationships, on employment, on family planning, that we respect and we care about all of those things as well. So I'm so excited to continue to build this relationship moving forward, and just so happy that we could all be here today. Thank you.
Thank you as well. Representative Love.
Yes, sir. Thank you all again for the chance to come and talk to you about this important subject. And I'm certainly going to support any effort that's brought to me to help change laws, even if it's, on the level of helping with pharmacists or helping with doctors achieve more standards of care. Let me say this to those who are listening, though. Don't assume that legislators know about sickle cell. Part of what you have to do is educate us on sickle cell so that when someone else brings legislation, it's a little bit easier. I knew nothing about maternal mortality until Dr. Connie Graves brought me a bill dealing with a way to reduce maternal mortality. And then we created a maternal mortality review board that found that 85% of the deaths could have been prevented. Same with sickle cell. I knew nothing about it until Dr. Bond brought it to me, to the depth of it, rather, I'll say that. And so I'd encourage you to find out who your elected official is, find out who you voted for, and reach out to them and just send them a note, an email about the fact that you're concerned about reducing sickle cell in your city and in your state, and then open a dialogue with them and educate them on the importance of sickle cell. Because what happens is every other group does that. We got bombarded with emails from parents who had children suffer from autism. And next thing we knew, we were running a piece of legislation to have insurance companies consider covering a experimental autism solution. So the same thing that happened with sickle cell. So I just want to encourage you, reach out to your elected officials and educate them on sickle cell and what it is and how important it is to you. Thank you.
Thank you as well. Mr. Mosby.
Thank you. I want to thank everyone here. First of all, you all are now part of the HEAL Collaborative. Whether you like it or not, you're now here, and we want to welcome you to our family. This is so important. Representative Love is the man. He taught me everything I know about politics, and I just want to bow down to him. Dr. Martin, I see that guitar in your background. I'm a bass player too, so maybe we can get together and have a jam session. But this is important work, and we want to make sure that we stay connected. And HEAL Collaborative is here to be that important partner with you. Just reach out to us, and we're here to help. Thank you.
Thank you as well. I apologize, but the executive producer is giving me indication and it's time to close out. Once again, I need to thank all those individuals who are listening across the nation. We sincerely appreciate your participation. I think that we have a slide that can go up for those individuals if we did not get to your questions, where you can send that information into, as well if you have any follow-up information or questions regarding sickle cell disease, so we can make sure that we answer for you. At this time, once again, I would like to thank Mount Zion Baptist Church for your participation and close out by thanking our sponsors. But more importantly, I want to thank all the panelists on today for taking time out of your busy schedule for participating. We sincerely appreciate it, and there will be more to come in 2021. Thank you very much for participating.